Okay, now once you've gotten to the point where you understand that there are multiple carcinogens that can damage DNA, then the next point that you have to understand is that there are particular regulatory systems that when damaged will certainly increase the risk for tumor growth and progression. And so the next discussion that we want to have concerns these key regulatory systems. So the three key regulatory systems that we're going to discuss are, number one, the proto-oncogenes, number two, tumor suppressor genes, and number three, regulators of apoptosis. These are three key systems that can be disrupted by carcinogenic agents. And these are very high yield, very important. There's a significant amount of biochemistry that goes into them. So what we're going to do is we're actually going to discuss each of these in the subsequent slides. All right, what are proto-oncogenes? Proto-oncogenes are genes that are essential for cell growth and differentiation. All right, and when mutated, so all our cells normally have proto-oncogenes, and those proto-oncogenes are necessary for cell growth and differentiation. However, when a proto-oncogene gets mutated, then it becomes something called an oncogene. And oncogenes, what they do is they lead to unregulated cell growth. So oncogenes lead to unregulated cell growth. Here are the key categories of oncogenes. The categories of oncogenes include growth factors, growth factor receptors, signal transducers, and cell cycle regulators. I think the best way to understand this notion of oncogenes is to go back and just remind ourselves of normal cellular growth. And so I'm going to go ahead and generate a whiteboard here and just draw you a simple picture to remind you of something. Let's pretend that this is a cell, okay, and this cell has a growth factor receptor on its surface. Now, when this cell needs to divide, and there will be times when a cell needs to divide, either because it's constantly turning over or because there is some sort of repair or regeneration, etc. When this cell needs to divide, what happens is that growth factor comes in, and growth factor binds the growth factor receptor. And growth factor binds growth factor, the binding of growth factor to growth factor receptor sends a signal, and this signal is carried by something called a signal transducing molecule. And so a signal transducer will carry the signal to the nucleus, and within the nucleus, cell cycle regulators and nuclear regulators will get activated, which will then cause the cell to cycle through G1S, G2, M, and that's the normal cell cycle. All right. So this is sort of the normal growth sequence, and each of these steps involves oncogenes. So oncogenes include, or why don't we say, because we're discussing the normal, each of these steps involves proto-oncogenes. So one type of proto-oncogenes would be the growth factor. Another type of proto-oncogene would be the growth factor receptor. Another type of proto-oncogene would be the signal transducer. And then another type of proto-oncogene would be the cell cycle regulators. So this is sort of the normal. Now, in each of these cases, mutations in any one of these steps or any one of these subtypes or categories of proto-oncogenes can result in the formation of an oncogene and can then be associated with formation of a tumor. And that takes us then to this table, which is present within your text. And again, it's a fairly dense table, and so it might be easiest for you to follow along in your text here, and then to write in the margin some of the notes or some of the points that I may make. So let's take this step by step. All right, the first category of oncogenes are growth factors. So that's way up here at the top of this table, and one of the classic examples of this is astrocytoma, which is a tumor of the astrocytes of the brain, which are a type of glial cell. All right. Now, I don't want to get into the details of what an astrocytoma is here, but I want to highlight to you that in this particular case, what happens is that there is overexpression due to mutation of this growth factor, platelet-derived growth factor B, and platelet-derived growth factor B gets overexpressed, which then drives the formation of an astrocytoma. So let me do this via illustration. So let's pretend that this is a cell, this is an astrocyte, and let's pretend that this astrocyte simply has a platelet-derived growth factor receptor. Okay? And normally, when platelet-derived growth factor binds the receptor, the astrocyte then divides. Now, what happens in this particular case is that you get a mutation so that the astrocyte begins to overproduce platelet-derived growth factor. And if the astrocyte begins to overproduce platelet-derived growth factor, it can actually then sort of swing around and hit the same cell through this signaling mechanism, which then results in overgrowth of the cell, i.e. the extra platelet-derived growth factor keeps hitting the receptor then sends signal to the nucleus then recognizes that it needs to divide, and so this cell grows. And this becomes sort of a vicious cycle in which the cell keeps growing in an unregulated manner and eventually produces an astrocytoma. And so that's the classic example where patients have a overexpression of platelet-derived growth factor, which then in an autocrine loop results in the overgrowth of astrocytes producing an astrocytoma. So that's the first classic example of an oncogene mutation or a mutated gene, i.e. oncogene, resulting in formation or being associated with formation of a tumor. All right, so that's one example. Another example would be growth factor receptors. Another example, growth factor receptors. So again, we can go back to our diagram, and we can remind ourselves that if this is a cell, and the cell is expressing a growth factor receptor, right? Here it is expressing a growth factor receptor. When growth factor comes in, all right, if normally what would happen is growth factor would bind the receptor, signal would be sent, and the cell would then divide. However, if you've got way too many receptors, let's say there's a mutation and there's overexpression of this receptor, then a simple stimulus of growth factor is going to result in 1,000 times or 100 times signal to this cell to grow and divide, and so this cell will begin to grow and divide out of control. And that will eventually result in the formation of a tumor. Now, what are some important growth factor receptors that can become mutated, and what tumors are they associated with? Well, one of the very high yield growth factor receptors is HER2/neu. All right, HER2/neu is a growth factor receptor. It's an epidermal growth factor receptor that is amplified in a subset of breast cancers. And why is this important to be familiar with? Because it ties back into pharmacology. And you'll remember from pharmacology that there is a designer antibody called trastuzumab. The other name is Herceptin. But there is a designer antibody called trastuzumab which is designed against the HER2/neu receptor. And so patients who have overexpression of HER2/neu, i.e. amplification of HER2/neu, that results in breast cancer, in a subset of breast cancer, can be treated with trastuzumab. And there's a classic examination question in which you could be asked, a patient, I don't know, we can make up a question that's sort of along the same principles. Patient comes to you having read, a patient with a history of breast cancer comes to you having read an article in the newspaper in which she sees that there is a new treatment for breast cancer that is designed against, that is a designer antibody against a growth factor receptor. So we could ask them, which of the following tests would be important to perform in order to determine whether or not she should be treated with the drug? A, estrogen receptor, B, progesterone receptor, C, HER2/neu, etc., etc. And obviously the answer would be HER2/neu. So it's important to be familiar with, and I would basically say that in a subset of breast cancer, there is amplification of the HER2/neu growth factor receptor. And so that's an important growth factor receptor to be familiar with. Another very important growth factor receptor to be familiar with is RET. And the key association with RET is medullary carcinoma of the thyroid, in particular medullary carcinoma of the thyroid associated with MEN2A and 2B. Now, this requires a little bit of discussion. So what's MEN? MEN is multiple endocrine neoplasia, It is a syndrome in which patients develop tumors in multiple endocrine organs, and it can be divided into MEN1, MEN2A, and MEN2B. And in MEN2A and 2B, one of the common tumors between each of those 2A and 2B is medullary carcinoma of the thyroid. Now, this is a very high yield association because if you suspect MEN 2A or 2B in a patient, let's say a patient has some of the other features of MEN 2A or 2B like pheochromocytoma and I don't know, mucosal neuromas, as would be seen in MEN 2B, then those patients who in whom you suspect MEN, you can do RET studies. And if the patient has a RET mutation, then what you'll actually do is prophylactically remove the thyroid, i.e. the thyroid will be removed before a tumor can actually form. And because medullary carcinoma of the thyroid could potentially kill the patient. And so testing for RET mutation is a very important feature of how we might deal with patients who have familial or MEN2A or 2B associated medullary carcinoma of the thyroid. So that actually is a very high yield association. And I'm going to give you much more detail when we do the endocrine lectures. I'm just again planting some seeds. Another important growth factor receptor is the KIT growth factor receptor, and a mutation in the KIT growth factor receptor is associated with something called gastrointestinal stromal tumor, and that's an important association to be familiar with. Okay, the next group of oncogenes are signal transducers, and the idea here is that after the growth factor receptor is bound, it will send a signal using a transducer to the nucleus. Now imagine for a moment, let's go back to our whiteboard, let's say that this is the cell, and we've got this receptor here. If growth factor binds the growth factor receptor, then a message will be transduced and that message will go to the nucleus. Now normally, for one growth factor receptor molecule, you only want one growth factor receptor signal sent via the messenger. Let's pretend that the messenger gets mutated so that the messenger keeps sending signal to the nucleus to grow. If there's massive signal heading to the nucleus to grow, the nucleus will obviously cause the cell to divide, and multiple divisions will eventually result in the formation of a cancer. And so that's the idea in this particular subtype of oncogenes, and that is that if there are mutations in signal transducers, that'll result in the formation of a cancer. And so what are some classic ones to be familiar with? Well, the first and probably the most important is the RAS signal transducing protein. Why is this important? Because it is commonly mutated in a large number of cancers. In fact, I think up to 70 to 80% of human tumors actually have have a RAS mutation associated with that tumor. So it's seen in multiple carcinomas, it's seen in melanoma and in lymphoma. So a broad range of human cancers actually have a mutation within the RAS signal transducer. This then requires us to go into a little discussion of biochemistry. So I'm going to take a step back here. This discussion is written in your book, but I'm going to go ahead and present it here because it's the perfect place in which to have this discussion. And so I'm going to simply go back and produce my whiteboard and just let you know a little bit about RAS. So what's the idea with RAS? Let's pretend that this is a cell, okay, and the cell clearly has a receptor, right, and growth factor would come in, and growth factor would bind that receptor. Now, when growth factor binds the receptor, one of the molecules that can be associated with the receptor is actually called RAS, R-A-S, okay? So that's RAS. Now, when RAS is associated with a receptor, it usually sits in its off state, which is basically RAS associated with something called GDP, all right? Now, the moment that growth factor receptor binds the receptor, the GDP gets kicked off, and instead RAS gets associated with GTP. And when RAS gets associated with GTP, the RAS-GTP complex then can send message down to the nucleus. And that's the key notion of that's the key way by which RAS works. Now, because RAS-GTP, when associated together, has the ability to carry the message down to the nucleus, you don't want too much message sent to the nucleus, you simply want a message sent to the nucleus. And so RAS also has the ability to cut away one of the phosphates so that the GTP becomes GDP, allowing RAS to become shut off. And RAS has the ability to cut away that phosphate. This is so important that there is an additional molecule associated with RAS, which is called GAP, which is GTPase associated protein. And the GTPase associated protein helps RAS to cleave that phosphate to shut off the on form or the active form of RAS. Now in RAS mutations, one of the common mutations is a mutation in this associated protein. So that if this GTPase associated protein is missing, RAS is going to have difficulty shutting off GTP or converting GTP to GDP, and therefore will not be able to shut off. And so when RAS remains associated with GTP, this will send excess signal to the nucleus, causing the cell to overgrow, right? And that's the key issue concerning RAS. So the biochemistry of RAS is important, and the fact that it's associated with so many human cancers is important and makes this molecule high yield, and that's why I spent a little time going over it. Okay, so that's RAS, and let's see what we say here in the book. The RAS-G family is a GTP binding protein, okay, and a mutation within RAS, in particular within the GTPase activating protein present within RAS, can result in multiple human cancers. All right, next important signal transducer is the Abl signal transducer. This is a tyrosine kinase. When there's a 922 translocation, there is overactivation of this tyrosine kinase, and this overactivation classically results in CML. So this is another example of overexpression of a signal transducer. Now, it's important to note that the 922 translocation defines CML. It defines CML. But also I would be aware of the fact that the 922 translocation is also seen in some types of ALL, and in particular in adult ALL. Now remember that ALL is basically a disease of children. However, in some in adults that form ALL, there is an increased propensity to have this translocation, a 922 translocation. It's also called pH positive ALL, i.e. Philadelphia chromosome positive ALL, because the 922 translocation is also called the Philadelphia chromosome. And recall that ALL actually has a relatively poor prognosis, i.e. ALL with a 922 translocation has a relatively poor prognosis. So that's another type of oncogene that can be mutated, i.e. signal transducers. The next type of oncogene that can be mutated are the nuclear regulators. And the nuclear regulators, they're basically a group of transcription factors, and these transcription factors go to the nucleus and cause upregulation of genes necessary for growth. Okay? And so those are nuclear regulators. And the most important nuclear regulator is MYC, MYC. That's the most important nuclear regulator. And what I would remind yourself of here is that the three key MYCs to be familiar with are CMYC, which is associated with Burkitt's lymphoma, NMYC, and the N helps you to remember neuroblastoma, and LMYC, and LMYC is associated with small cell lung carcinoma, and so the L will help you to remember lung. So each of these are transcription factors. MYC is a transcription factor, and upregulation or overexpression of the MYC gene will result in overproduction of growth promoting proteins, and that will result in overgrowth, increasing the risk for development of a particular type of cancer. Now, one thing that I would like to highlight here is the fact that when you have a c-Myc translocation, that will result in Burkitt lymphoma. All right, and it's important to note here that the c-Myc the mechanism by which c-Myc is overexpressed in this particular in a Burkitt lymphoma is usually a translocation between chromosome 8 and chromosome 14. This requires a little bit of discussion, and so I'm going to again create a whiteboard to highlight some of this, highlight an important principle here. Okay, now let me just remind you that Burkitt's lymphoma is actually a lymphoma of B cells. That's important to note, and that B cells normally express immunoglobulin heavy chain. All right, so this is immunoglobulin heavy chain, and immunoglobulin heavy chain sits on chromosome 14. All right, so imagine that this gene is basically on. Okay, and let's say that the patient gets a translocation with the MYC gene, which in this particular case is on chromosome 8, and so this translocation will result in the switching of immunoglobulin heavy chain with MYC, so that when MYC sits in this position, so this now is going to become MYC because of the translocation, MYC will also will actually be turned on, because this position in the chromosome or this location in the chromosome is an on location in a B cell. And so what will happen by this translocation is that there will be massive overproduction of MYC, and that massive overproduction of MYC will result in massive growth of the tumor. In fact, do you recall, or maybe you haven't studied yet, and so I'll have to tell you, that Burkitt's lymphoma, one of the key histologic findings in Burkitt lymphoma is called a starry sky appearance. And the idea behind the starry sky appearance is that the tumor cells represent the sky, and the tumor cells are very blue, but the stars, the little white areas that are interspersed between the tumor cells, those white areas actually represent areas of macrophages eating cells that are dying. And the idea here is that the cells are growing so rapidly that they actually grow and die, and they grow and many of them die, and so the macrophages consume them as they're dying, producing that starry appearance in the background of the blue lymphocytes. Anyway, the idea here is that overexpression of MYC results in massive overgrowth of the cells, and the mechanism by which MYC is overexpressed is that it gets translocated onto, in this particular case, chromosome 14. All right, so it is important to be familiar with the fact that MYC sits on chromosome 8, and that it can be translocated to chromosome 14, which is the immunoglobulin heavy chain locus, and then eventually resulting in overexpression. All right, so I would say that that's pretty much what I would like to say about nuclear regulators. And I'm going to, by the way, rediscuss Burkitt's lymphoma when we do the white blood cell lecture. Okay, so now let's go to the final group of oncogenes, and these are the cell cycle regulators. And so it's important to, sorry about that, cell cycle regulators, right? And it's important to note that the cell cycle regulators are proteins that assist movement through the cell cycle. So let's go back and create a little whiteboard. Remember that cell cycle basically consists of G1S, G2, and M. Now, sorry, G2 and M. Now, important to note here that the G1 to S phase is the most highly regulated of the cell cycle. And the idea here is that before you put a cell into S phase where the DNA is going to be copied, you actually want to make sure that, number one, the cell should be going into S phase, and number two, that the cell goes into S phase without carrying any mutations in its DNA, because you don't want to pass bad DNA off to onto the offspring. And so G1S is highly regulated, and cell cycle, G1S is, why don't I go back? The entire cell cycle is highly regulated, in particular G1S. So that's basically what I'd like to say there. Now let's go back and talk a little bit about these cell cycle regulators. So the two important cell cycle regulators to be familiar with are, number one, cyclin D, all right, and its association is with mantle cell lymphoma, all right. So cyclin D1 with mantle cell lymphoma. Now again, you need to know for board examinations and generally speaking that mantle cell lymphoma is basically due to an 11-14 translocation. So let's go back and create a little whiteboard and again highlight the same principle. So mantle cell lymphoma is a lymphoma of B cells. All right, actually, why don't I take a step back? Let's create another whiteboard and just explain something. What is a mantle cell lymphoma first? So here's a lymph node. And remember that within the B area of the lymph node, the B area is the cortex of the lymph node. That's where the B cells live. Within the B area, you have follicles. So this is a follicle. And outside of the follicle, you have a region called the mantle. All right. And outside of the mantle, you can develop a region called the margin. So these are sort of the three key regions that can be seen in the B area. So from each of these regions, we can get a tumor. For example, we can get a follicular lymphoma, a mantle cell lymphoma, and a marginal zone lymphoma. Now, mantle cell lymphoma, which is what we're now talking about, and so let's create another whiteboard. Mantle cell lymphoma is driven by something called the translocation 11-14. Now, what happens there? Well, these are B cells. And B cells normally are overexpressing immunoglobulin heavy chain, which sits on chromosome 14. Okay? And imagine if cyclin D, all right, which sits on chromosome 11, gets translocated to the immunoglobulin heavy chain spot, so that now what's sitting here is cyclin D. Then you're going to get overexpression of cyclin D. And what does cyclin D do? Cyclin D allows the cell to go from the G1 to the S phase. All of this is high yield, shows up on examinations. What do I mean by all of this? Well, first of all, you need to know that in mantle cell lymphoma, you get expansion of the mantle. So, for example, sometimes they give you a description on an examination where they say that a biopsy of the lymph node is performed and it shows expansion of the region next to the follicle. So what's the region next to the follicle? The mantle. So that's one important thing to know about mantle cell lymphoma. Another important thing you have to know is the translocation. It's an 11-14 translocation. You need to know that on chromosome 14 is immunoglobulin heavy chain, and that's the region where the translocation occurs, and that the key gene that's being translocated is cyclin D1. And that cyclin D1 is important to go from the G1 to the S phase. That's also an important biochemistry question. I remember vividly that on one occasion, I tell my students, and I'm telling you, you're a student, that that I really see the board exams and other examinations, if they're well written, as thinking exams. And one of the students once came up to me and complained and said, well, you know, I had a really foolish question on my exam where I was asked about, you know, on what chromosome is cyclin D1? And, you know, he was arguing with me saying that, well, see, that's not really a thinking question. That's a nitpicky fact memorization question. Well, actually, in a way, it is kind of a thinking question, because if you know that the key translocation in mantle cell lymphoma is actually an 11-14 translocation, and you know that on chromosome 14 is immunoglobulin heavy chain, then you can kind of go back and derive from that cyclin D1 is on chromosome 11, because cyclin D1 is this key gene that's involved in the 11-14 translocation. So anyway, basically what I want to get at is the fact that you do need to be familiar with cyclin D1, you do need to know about the 11-14 translocation, and that it is associated with mantle cell lymphoma. And so that's probably the key points that I'd like to give you from this particular table. The last one is CDK4, which is a cyclin-dependent kinase, which is related to melanoma. Not really the highest yield, but I put it here for completeness sake. So these are cell cycle regulators.